Thanks. So by way of formal introduction, I'll tell you who I am now that I've already kind of spilled the beans, right? My name is Banko. I'm an associate professor of molecular medicine in the College of Medicine at USF. I predominantly spend my time as the Associate Institute Director and Chief Operating Officer of the Alzheimer's Institute. In my role as the Chief Operating Officer, I oversee the Discovery Research Laboratories, our community research, our caregiver and lay professional development programs, as well as all of our administrative functions. Today, I'm going to address with you some general themes that are emerging in Alzheimer's disease with respect to both the management and treatment of individuals who are today living with the disease, as well as what is on the horizon for tomorrow. What approaches are currently being pursued on the research front, both for individuals who are diagnosed as well as the younger population who may be at risk. So we're going to talk not only cure or reversing the disease, but we're going to talk about prevention. I'm going to have to kind of stand more in the middle because I came not quite as prepared as I should in terms of slide progression. But the first thing I want to talk about, Bernadette gave us such a wonderful introduction to cognition that I can just kind of fast forward now that we all understand what we're talking about when we discuss cognitive ability or cognition. This is what that black box brain outcomes are. And at the Institute, we are missioned to address not only treatment and management of Alzheimer's disease and research towards a cure, but our programs are designed to benefit caregivers and individuals of dementia at large. And so often the first question that is asked to me when I give a presentation is, what is the difference? Are they distinguishable? What is dementia versus Alzheimer's disease? Or I've had a number of individuals visit the table this morning and say, my husband does, or my wife, or the person I'm giving care to doesn't have Alzheimer's disease, they have dementia. And so let's talk about what exactly is dementia to begin with. Dementia and Alzheimer's disease are often used interchangeably in conversation. And in some cases that's appropriate, and in some cases it isn't. Dementia is kind of an umbrella term. It is a descriptive group of symptoms that people can show outwardly to the rest of the world. And it can be caused by a number of different health conditions. So dementia is experiencing trouble with your working memory. Maybe it is having aphasia or apraxia. This is when you have that tip of the tongue feeling, you know the word you want to say, or you feel like you should know the word, but it's just not coming. That's having the knowledge of how to execute activities of daily living, but not being able to do them in either the correct sequence or with the same effectiveness that you feel intellectually you should be able to, but you just can't will the body or will the parts to get it done in the way that you wanted to. Perhaps it's having trouble navigating to the store, to common locations that you've frequented all of your life or multiple times a week, and now you find yourself getting lost on the way home, possibly not knowing where you are in time as far as the date and as far as current events are concerned, kind of getting caught up in a past experience or a past time in history, not understanding those around you are who they are today in November 2016 and mistaking them for somebody, a family relation or a friend or companion from an earlier time in your life. Those are all symptoms. And when put together, we would call those symptoms dementia. But the disease or the health condition that is happening to the body that is causing those symptoms of dementia can be many. And if we were to make a pie chart out of all of the different health conditions that could cause those symptoms of dementia, we would find that predominantly the cause or the culprit is Alzheimer's disease. About 65, some statistics show upwards of 70-75% of the time. It is Alzheimer's disease that is happening in the brain and giving rise to those outward symptoms of dementia. Less frequently, albeit a large portion of the pie, is cardiovascular disease. So if you've had a one major stroke event or multiple small events, you may have heard them referred to as TIAs or mini strokes. Once you have suffered a series of those, the combinatorial effect can give rise to dementia. There are different diseases of the brain that are similar to Alzheimer's in that there's stuff in the brain that doesn't belong there, but it's not Alzheimer stuff. And where they reside in the brain gives rise to different diseases like Lewy body disease, frontotemporal dementia, or Pick's disease. These are all dementing conditions. And then there is also a group of health conditions that are readily treatable and reversible associated with our metabolomics or our diet and nutrition. So having a thyroid condition that has gone undiagnosed or untreated or mismanaged can give rise to symptoms of dementia, but could be readily addressed. Having nutritional imbalances in some critical vitamins, like vitamin B complex, or also in folic acid and other nutritional supplements that the body needs, can cause dementing symptoms. Simply having an untreated infection. A lot of women, for example, as we become older adults, we can experience UTIs that don't actually come with the accompanying pain of when we were a younger female, and so we don't know we have a urinary tract infection, and if left untreated, can give rise to symptoms of dementia. So there's a big pie of health conditions that cause dementia. The reason we so frequently default to Alzheimer's disease is because, as I said, it does occupy the largest proportion of that pie. But importantly, there are other conditions, and this is why it's so important that we have a comprehensive diagnosis performed by an expert who can rule out, importantly, those reversible or treatable forms of health condition that give rise to dementia. And because what I'll discuss are some of the management strategies, the pharmacological, the drugs that are available for the treatment of Alzheimer's disease are sometimes specific to Alzheimer's disease and may be counterproductive if given to somebody with a different form of dementing condition. So that's kind of the first lesson we're going to learn today. So what is Alzheimer's disease? We know that the symptoms of Alzheimer are dementia, and we just discussed what those are. But what is actually happening to the brain that's causing those symptoms? That's what's on the image up here. It is twofold, and you must have both features in order to have Alzheimer's disease. It's an actual change in what the brain looks like and is composed of. The first change happens outside of the cells. And if you imagine all of us in this room as cells of the brain, then we would all be called neurons. And our job would be to connect and talk with our neighbors. And all of those connections would be unique and specific to different sensory input or memories that we have. And so it's kind of like if we put our fingers together, our locked hands, and maybe wrapped our ankles together and played the game of telephone, like from when you were a child, and you start the message by squeezing your hand. And I whisper something in your ear, And then you go along and we form a whole network. And by the time it comes back to me, we see if the message is the same. This is that game of telephone. It's kind of how the neurons of the brain work. They physically connect with one another, and they pass messages along their network. And those messages are the memory traces themselves. They are unique and specific. The pattern with which it lights up is unique and specific to each sensory event or memory we have. Now imagine, as we get older, a protein that's in our body. We don't ingest it. We don't get it from the environment. We've been making it in our body since birth. It is from our genes, our DNA. And presumably all our life, it's doing something we need it to do. We're not sure what that exact job is today. But it's there and it's not causing us harm until a certain point where it stops behaving. Kind of like other things when we get older. It just stops behaving like it's supposed to. And when this protein stops behaving, it gets produced in a different shape, a different size, a different form. And it becomes very sticky. And it recruits all of other friends that are just like it. And it builds a wall between the neurons. So now, if you and I were neighboring neurons, and we were trying to play our game of telephone, and something happened to trigger our memory, but a wall of this protein called amyloid was built between us, do you think we'd have a very good game? No, we would be physically blocked by this wall. And that's what happens. This is the amyloid plaques that develop outside and between the communicating cells of the brain. This is the first feature that must be present in order for the Alzheimer diagnosis to be correct. The presence of these walls is twofold. Not only do they disrupt the communication that should be taking place, but the brain doesn't like them there. It knows they're not supposed to be there. And so it starts to mount an attack on them, but that attack is not very helpful. If you have a splinter in your pinky, brain knows it's not supposed to be there, right? And it mounts an attack, an immune response. And your finger starts getting swollen, and it's really sore to touch, and maybe it kind of gets pussy because your body's trying to eat away at that little splinter of wood in there. The same thing happens inside our brain in response to the presence of the amyloid walls. We mount an immune response. The area around the presence of the plaque becomes inflamed. The body is trying to account for this wall that's there and trying to get rid of it. And so all the cells around the wall get squeezed by the inflammation, and they start feeling like, I can't do my job. So not only are the cells right there that are prohibited from interacting by the plaque, but the environment all around the plaque is now feeling like, I can't get the job done. What happens when cells in their body know they can't get their job done? They die. We have programmed cell death as a response to cells that can no longer do what they're born to do. And so the cells around the plaques die. This is the first insult, the first change in our brain that happens when we have Alzheimer's disease and gives rise to those downstream outcomes of dementia. The second happens subsequent to the formation of the plaque walls, and this is a change inside the cells themselves. Now, the cells of the brain are very elegant. They're kind of like us. They have a beautiful body and long projections. It's those long projections that do the communicating, play the game of telephone, and it's the cell body that generates the energy and generates all of the components of the cell that make that job possible. But those things have to get from the cell body all the way out to the long projections. How do they do that? Kind of like how we get our Tropicana oranges to everywhere else in the country, along a railroad system. And that railroad system is supported by an infrastructure of tau protein. The tau proteins are like the railroad ties holding the tracks in line. And again, like amyloid, it doesn't get managed properly as we age. And what happens is it doesn't hold the tracks in alignment. And so that infrastructure gets all tangled up inside the cell. If you look under a microscope, it actually looks like a tangled up kind of hairball inside the cell. And that is why the second feature of Alzheimer is called tau tangles. We're not that creative. We've got amyloid plaques and we have tau tangles. Both of these features are developing inside the brains of individuals with Alzheimer's disease. And as a result, the cells can't do their job and die. This is why we have the outward symptoms of dementia. Does that make sense? It's important for that to make sense to everybody before we go on. Okay, so now that we know what it is, what is our risk for having this happen? For having the plaque walls begin to build and the tangles begin to form? Well, the first four features we just described is advancing age. We know the more birthdays you enjoy, the greater your risk of developing Alzheimer's is. 1 in 65 have Alzheimer's disease. That advances to almost 2, if not 3 to 1 of individuals 85 years old have Alzheimer's disease. So advancing age, for the reasons described, the mishandling of amyloid protein and tau protein causes the walls to build and the tangles to form and gives rise to Alzheimer. The second is our family history. If we have a mother, a father, a sibling, or a child with Alzheimer's disease, it does increase our likelihood of developing the disease. It is not, however, our predetermined legacy. We're going to talk a little bit more on the next slide about this. But our family history does impact risk, and it is one of those things we can't change. We can't change our birthdays. We get older whether we try not to. And we can't change our family history. The things we can change, however, are head trauma. Head trauma, regardless of when in your life you experienced it, as a child, perhaps falling off a bicycle, playing contact sports, as an adult, traffic injuries, participating in military activities, even just falling in our homes or in other environments. All of these activities can give rise to head injuries. And head injuries does increase our risk for developing Alzheimer's disease. Finally, there is definitely a heart-head connection. All of the risk factors you hear for cardiovascular disease are the same risk factors that cause Alzheimer's disease, or I shouldn't say cause, that was phrased incorrectly. Increase our risk for developing Alzheimer's disease. So not managing diabetes, eating a fat-laden or cholesterol-laden diet, not maintaining good physical activity, all of the things that give rise to poor cardiovascular health give rise to Alzheimer's disease as well. We need to maintain good flow and bathing blood around our brain to provide it with nutrients, to provide it with all of the goodies that the brain needs, just like the rest of our body, to survive and thrive. And so eating a heart-healthy diet is very important for minimizing the risk. Those are the risk factors we can control. So that was wearing your seatbelt, keeping your home free of clutter so you minimize falls, taking any precaution you can to keep that head safe, eating a diet that is rich in vitamin B, folic acid, your leafy green vegetables. This is very important. Fruits and vegetables that are high in antioxidants, like your blueberries and a variety of berries, actually. One is often refers to the Mediterranean diet. This is very low saturated fat, but high omega-3 fatty acids, so lots of fish, You're minimizing your red meat, keeping it in your diet, but not the primary focus of your diet. If your grains should be whole grains, more complex carbohydrate to break down and utilize as fuel, so wheats, multi-grain breads, high fiber breads, those are going to be not only heart healthy, but brain healthy. As we just heard a lot about, staying socially, intellectually, and physically engaged makes a difference, and not only relying on one aspect. I don't want to discourage anything that you're doing today, but I want to emphasize breadth. I want you to think about how can you create variety in those activities. Don't rely exclusively on the crossword puzzles. Mix it up a bit, right? Play your pickleball, play golf, join a card group, a book club, pick up an instrument. You don't have to be Mozart. Just pick it up and start tooling around on it. Rosetta Stone is available online. Just dabble in a new language. You don't have to become fluent. Just try to keep all of the aspects of our cognitive ability engaged and stimulated. That will go a long way for reasons I'll describe in a few minutes. And then finally, anything again that is heart healthy, including your physical levels of activity, is brain healthy. So we talked that one of our risk factors that we can't control is genetics. And the second most frequently asked question of me at a lot of my talks is, if I'm caring for somebody, or if I have, because lots of folks in the early stages of Alzheimer's disease are very aware and appreciative and frustrated by what they're experiencing, and still have the brilliant ability to articulate that frustration and their concerns. And the first concern is this my legacy? Is this what I'm going to leave on to my family and those who come after me? And it's somewhat a complicated question. And I'm going to attempt to break it down here so that you have a better idea that that is not what you should be afraid of, that is your living legacy. Most of you in the room, if you are a caregiver or a neighbor or a church member of somebody with Alzheimer's disease, it is very much likely that that person developed Alzheimer's disease as an older adult. And the form of Alzheimer's that affects older adults, those who are 65 thereabout or older, is called late onset Alzheimer's disease. The genetic association of late onset Alzheimer's disease is it's still fairly a black box. What we do know is we've spent a lot of money, not we, the Institute, we, the world, have spent a lot of money trying to understand what the genetics of late onset Alzheimer's disease is. And nothing comes out with a high correlation. And that's because there aren't any genes that are absolute predictors of late onset Alzheimer's disease in the yes, you will get it, no, you won't category. Okay, these are called risk genes. These genes only modulate risk, much like the risk I described on the former slide. They can increase the potential for you to develop it, or they can bring down the age at which you were going to develop it. But they're not sentences, so to speak, in that if you are born with the particular gene, you're going to have Alzheimer's. The other form of Alzheimer's disease is called early onset. And I won't ask you to show by hand how many of you are impacted by early onset, but if there were more than one of you in the room, it would be somewhat surprising, because there are only thousands of these cases in the world. They are familially inherited. They are the predetermined genes that you inherit from mom or dad that are the absolution. Yes, you will get Alzheimer's disease. They are a much, much smaller population of individuals, and these are the individuals who start to experience the symptoms of dementia at a young age, late 40s, often experiencing the full outward display of dementia and Alzheimer's disease by their early to mid 50s. If anybody saw the movie Still Alice with Julia Moore, That movie depicted an individual with early onset Alzheimer's disease. So on the left-hand side of the screen is the case that most of us either know firsthand or know somebody living second or third degree of separation with. And this is late onset Alzheimer's disease. There is one known gene family that is very highly correlated with risk. That gene is called apolipoprotein E, ApoE. It comes in 3 flavors, and we inherit 2 copies on our chromosome, one from our mom and one from our dad. The 3 flavors are ApoE 2, 3, and 4. If we inherit ApoE 2 from either our mother or father, it is thought to be neuroprotective. It reduces our risk for developing Alzheimer's disease. It doesn't protect us against it, in that if we have a copy, or 2 if we're lucky enough to get one from mom and dad, it doesn't say we're never going to get Alzheimer's disease, because it's just sliding the scale of risk. If we get it, maybe it happens at a later age. Maybe it serves to counteract some of the other habits we adopted in our lifetime that increased our risk. But it isn't absolute in that we won't develop Alzheimer's disease. It is just thought to be a reducer of risk. The second, ApoE3, is what is most commonly found in the population, and it doesn't appear to have any effect on risk in the positive or negative direction. So we would call it benign. The third flavor is ApoE4. ApoE4, when inherited from either mom or dad, increases our risk. If we inherit 2 copies of ApoE4, one from mom and one from dad, it does more than just an additive risk. It dramatically increases the likelihood of the development of Alzheimer's disease, and may even cause it to happen at a younger point than it would have otherwise in our lifetime if we didn't have that genetic type. When we talk about the idea of getting genetic testing for Alzheimer's disease, and it's just you or I who are worried, maybe mom or dad or a family member or a long list of family members has the disease. We're in our 60s, we're thinking about our long-term plan and our family's legacy, and we want to know, is this something I need to worry about? I hear there's a genetic test for Alzheimer's disease. This is the testing that is available. It will tell you which flavor of ApoE gene you are. But I just told you it doesn't necessarily mean anything ultimately with regard to you will develop it or you won't. And so in our clinic at the Alzheimer's Institute, and in a vast majority of clinics, we do not routinely include genetic testing for ApoE genotype in a workup for somebody with late onset Alzheimer concern. Sometimes we do it, but it is only when it is called for because you're participating in a particular research study, or in the future, we may do it if it plays a role in personalized medicine. Maybe your genotype will affect how you respond to different treatments. But as a rule, for diagnostic purposes or alleviating concern, we don't do it. And I caution, if you submit yourself to that kind of testing, that you don't do it with a general practitioner, but do so with the partnership of a genetic counselor who can share with you what the outcome, what the findings really mean in terms of your own planning as well as your family legacy. Now, the deterministic genes that I shared with you, there are a couple, 4 or 5, and these are actual mutations. These aren't isoforms that are available in different kind of ice cream flavors. These are actual mutations to the genes that produce the amyloid plaques that I described earlier. And when you are born with these abnormalities in your genetic code, as a result of mom or dad passing them on to you, then you will almost certainly develop Alzheimer's disease, and it will happen at a younger age. The reason it happens at such a young age is because from the day you're born, I told you these proteins are being produced in our body. And so from the day you're born, you are producing them abnormally because of the anomaly on the gene you inherited. And so the plaque walls build over your lifetime, and you experience the deleterious effects of the plaque at a younger age. All of these mutations are present on a gene for presenilin. This is the enzyme. This goes beyond. You know, if you want to check out for this 30 seconds, you can. This is the enzyme that is responsible for processing amyloid. Amyloid is a very long, big protein. And when we make it as a very long, big protein. But our body doesn't use it that way. We have to break it up into smaller fragments in order to send it off to do its job. And as we get older, we make a new fragment that we don't make for the rest, usually for the rest of our life. And it is that fragment that is the sticky guy that builds the walls. And so if we have present the enzyme from a very early stage of our life that cuts it up into that naughty fragment, that's why we start building the walls early, and we are predetermined to have Alzheimer's disease in our lifetime. Okay, so maybe that's not the case for those of you in the room. Maybe you aren't giving care to somebody with Alzheimer's or living with it yourself, and you want to know, how do I know if I'm at risk, or how do I know if my memory is changing? Kind of, you know, wasn't able to answer that question about what I ate for dinner last night, or forget often where I misplaced my keys. These are the kinds of things that we talk about. Over the natural course of our life, we have normal age-related memory loss. I hate to say it, it's normal. We will all experience a certain degree of cognitive decline as we get older. Bernadette showed in a slide that had several different features of cognition and how they change in most cases, or in many cases, decline as a function of aging. So that is indeed normal. This slide shows you when it's not normal, what to look for and what the stages are called. The very earliest stages of change are referred to as mild cognitive impairment. These are changes that don't necessarily disrupt our activities of daily living. Many of us can continue to remain gainfully employed in our careers or our, whatever our professional or hobbies were. We stay extremely engaged socially, physically, but we recognize that some of those activities become more challenging or frustrating to execute. And often we just kind of don't really pay close enough attention. And it's nothing that is so severe that it drives us to the doctor. And after a while, it starts to become a little bit more profound. And maybe our spouse or our children start nagging us about it, constantly calling our attention to what we're forgetting, misplacing, recalling incorrectly. That's when we either decide to shut them out or go to the doctor for the first time. The problem is, once we've arrived at that point where it is already being projected as a symptom of dementia, the plaque walls and the tangle formation that gave rise to those symptoms several of those dominoes have already fallen. They start to be built sometimes as early as 15 years before the symptoms. We refer to this as that preclinical phase. It's the silent phase. We're not looking at our brains under a microscope, so we don't know those walls are being built. We don't know the tangles are forming. And we haven't yet lost enough material of our brain. Enough cells haven't died that we are experiencing the consequences of not having them to do their job. Once we do, we go to the doctor and we get diagnosed with the condition. But it's really that preclinical, that window there where you start to see the parsing out of the blue line from the green line, that therapies that are currently FDA approved are most efficacious. They're going to be most effective in terms of slowing the progression and allowing you to maintain the level of function you're enjoying. So it is really important to not wait until everybody around you is nagging you and you've become so frustrated and discouraged by the challenges you're facing every day that you finally go to the doctor. You need to address that not once you see the symptoms, but as a routine health activity. We go to the doctor every year, I'm sure. All of you go for your annual wellness exams. Medicare pays for it. It's not a very large copay. You need to demand that your brain health is part of the package that's being evaluated at those annual wellness exams. How do we do that? Something called memory screening. This is not invasive. This is a very simple approach to determining, when we're still healthy even, what is our baseline function of cognition. The tests are designed to query all of those different aspects that Bernadette described. Processing speed, short-term memory, working memory, delayed recall. It's a very short pencil and paper test. It can be done in the privacy of your doctor's office or a small church room, as I'll share with you, in about 15 to 30 minutes, depending on your performance. Now, what is it and what is it not? It is just a screening, so it isn't unlike when you go to the pharmacy and you do a blood pressure screening, okay? It's not diagnostic. It's not going to tell you you have Alzheimer's disease or cardiovascular dementia or Lewy body dementia or any of the other things we discussed in the big pie of dementing illnesses. But it is going to tell you if your performance on the screening is within the acceptable range or gives the screener reason for concern, and they will refer you to your doctor so they can do that comprehensive evaluation to determine what, if anything, is causing the change. It's included in your annual Medicare reimbursement. Your doctor gets reimbursed for this. There's no reason he or she should not make this available to you each year. And that is the recommendation. If you are performing within the normal range on your memory screening, you should take a memory screening test every 12 months. Now, you get your blood pressure checked every time you go to the doctor, right? Men, we have prostate exams. Women, men, we have our colonoscopies. Females, we get our mammograms. There's no reason to ignore from the shoulders up on an annual basis and do this very simple screening exercise. It should be done minimally, as I said, annually at age 60 and up. We've actually started sliding that scale back. Some places I've seen advocate as young as 55. The reason for that is because the most promising research advances are in prevention. And who are we targeting with prevention? We're targeting that preclinical group on the last slide, where the normal age-associated decline and MCI start to parse out. And this is before you have symptoms, right? This is before 65. So we started actually moving back that recommended age of memory screening when you begin. And given how simple it is, there's no reason not to start doing it in your 50s. It should always be done using an evidence-based tool. What is that? What's an evidence-based tool? Sounds like malarkey. Sounds like science fanciness. Some examples of evidence-based tools include the Mini Mental Status Exam, the MMSC, or the Montreal Cognitive Assessment. These are two. There are a handful of them. But what evidence-based means is that a population has taken the test and it has been demonstrated both specifically and sensitively for that test to correctly identify people with a problem compared to people who don't have a problem. It's not the, I'm going to give you a word, I'm going to give you like 3 words at the beginning of our exam, and then at the end of our exam, 10 minutes later these days, as the primary care doctor, 10 minutes later, I'm going to ask you those 3 words again. That is not an evidence-based memory screening test. The evidence-based memory screening tests are often done with a pencil and a paper. They often include your interview, as well as drawing, as well as describing or discussing relationships about objects or items. So it should feel to you like you're having to do some maybe mental math. You're having to draw a picture of something based on an image you see. You're having to solve a pattern or a puzzle. You're having to remember a set of information now and then recall it later in the encounter. You should be experiencing a query or an investigation of how you perform cognitively in all of these areas in order for the memory screening to be valid. Because we may have a decline in one and not the others. Again, going back to what Bernadette shared, your language fluency or your speed of processing may change, while your ability to navigate spatially may not change. And these are what determines the sensitivity and the specificity of the instrument in question. So that is really important to ask your doctor, is this something that's licensed, that's for real, that's been demonstrated to be specific for diagnosing early forms of cognitive impairment? We have a program developed by the Alzheimer's Institute called Community-Based Memory Screening. I'm very proud to say that you have volunteers in Sun City Center, both through the Rescue Squad as well as through the Mental Health Coalition and others who have come together and submit themselves for a very rigorous training to be able to bring to you free memory screening right here. You don't have to travel all the way up to Tampa, you don't have to cross any interstates or bridges or anything like that. It's offered right here. This was a community-led initiative. Your peers and professionals in the community recognized the value of the service and wanted to bring it to you, so they contacted the Institute. They understand and they abide by giving it to you as a service free of charge. And they went through a very rigorous training program to become equipped to deliver the screening tools to you. And what that included was first identifying themselves as being an appropriate memory screening administrator. The term appropriate in our definition is they served a professional health capacity in their career, perhaps. They served as a steward of private information, of interpersonal relationship building in their former career. And they demonstrated their ability to learn in the didactic training and then perform at an 80% or higher on a test that we did after they did their training. We also went through robust role playing with them to see what the encounter would be like, and we go back and we do quality control auditing with them throughout the year. So we really have a tremendous group of professionals here in Sun City Center to do memory screening. In addition to knowing what your memory screening score is on the day in which you've done your assessment, they can also add you to a registry. The addition to the memory care registry means that if and when either a research trial or a new program that you may benefit from, whether it is education, whether it is prevention, or whether it is treatment, becomes available, we will contact you. We will reach out to you and say, there's something available, would you like access or to somehow participate? It is from the memory registry that we will be looking for our 7,000 participants, for example, to do the brain training trial that was touched on earlier. As I said, it's offered here. You should take advantage of it. Everyone in this room, there is no excuse for you not to get a memory screening. It's offered all throughout the South Shore area, and it's free. These are the locations that is currently provided by your certified memory screening administrators. It does require an appointment, and so take down this telephone number. If you can't see it, or in the time that it's here, I'll say it to you out loud, but come and visit me at the back table and I'll share it with you again. The number is 813-419-4902. Again, it's offered throughout the community. Aston Gardens, Sun Towers, Kings Point, Valencia Lakes are the residential communities. It's also offered at the United Methodist Church across the street. So depending on which day you're available or which location is most convenient, you can make your appointment for your memory screening.